Okay, Bismillah. Let's start our chest VIVA cases for today. Candidate one, your
Okay.
case
Yes,
22,
doctor. Can you hear me? Yes.
yes, 22 years old male patient fall down 12 stairs.
Doctor, please again, 12 years old,
22 years old
22.
male, 22 years old male patient complaining
Mhm.
of fall down 12 stairs.
Okay, okay. So this is a frontal chest radiograph for a 22 years old male patient with a history of falling down from stairs. Um, the lung volumes are preserved. The right paratracheal strip is thickened. There are multiple bilateral patchy pulmonary nodules and opacities over both lungs. The cardiac size is normal. No pleural effusions. No pneumothoraces. Um, the bones are normal. I can see no fractures in the available image. Okay, and there is no pneumomediastinal, no pneumothorax, no shift of mediastinal structures. So collectively, this is a prominent right or a thickened right paratracheal strip with multiple bilateral pulmonary consolidations or nodules. My preliminary diagnosis at this stage, given the history of trauma, would be multiple pulmonary contusions with severe mediastinal hematoma. I would like to convey these findings immediately by phone to the referring physician and recommend further evaluation by chest CT scan with contrast.
Okay. About your differential for this case, you called contusions, mediastinal hematoma. It's good as regarding the patient history, but anything else?
Yes, if we consider these not related to trauma, there are many other differentials involved in this patient. So, primarily could be infectious process like tuberculosis, for example. Also, other differentials include sarcoidosis, although the hyla could be more prominent in case of sarcoidosis. Other differentials are metastatic deposits. It's not compatible with this age, it's not unlikely. So, especially the patient has no history of primary tumor.
Okay.
These are the differentials in my mind. Nice.
So what will you do next for this patient?
I would recommend chest CT scan with contrast.
Okay. Here's the CT. You have the control. You can scroll.
Okay. Um,
Click once and scroll.
okay. Right. So this is axial chest CT scan in the arterial phase. I would like to request a few seconds to scroll through the images until the last cut, and then I'll convey my findings. Are these the whole stack of images? Because it's not scrolling anymore down. No, it's now scrolling down to the only
Scroll.
mid the chest, right?
Okay. Scroll up.
Okay. So this is limited chest CT scan, and it's for the upper half of the chest in the mediastinal window. You can see that there are multiple mediastinal enlarged lymph nodes, and the aforementioned right paratracheal density or opacity in the chest radiograph corresponds to one of these lymph nodes. The vascular structures appear intact. There is no evidence of aneurysmal dilatation or dissection. No pulmonary emboli as well, although this is not the optimal phase for this scan. Okay, and what is seen of the lower neck appears also unremarkable. There are no axillary lymphadenopathy. The trachea and bronchi appear patent. The adjacent soft tissues in the region appear
Okay.
also normal.
So
So yeah.
what are you
Yes, sir.
suspecting?
So, yes, given the age of the patient and multiple lymph nodes, I would suspect primarily a neoplastic process, mainly lymphoma. Other differential diagnoses are tuberculosis. So these are not related to trauma. These are
Okay.
incidental findings.
Can you go up? Can you go up slightly? Okay. Stop here.
Yes.
Can you look to the lung fields?
Look for the lung. Yes. There are a few peripherally located pulmonary soft tissue nodules. However, I would like to check these in the lung window to confirm the nature of them.
Here, the lung.
Okay. I'm afraid it's not scrolling, or maybe it's lagging. Okay. So as I'm scrolling up through the lung, I can see that there are multiple bilateral sub-centimeter pulmonary nodules, mainly in the periphery of the lungs. They are in upper lobe predominance, and there are a few tree-in-bed appearances, interlobular septal thickening, and I could spot a lesion also in the trachea, in the right side of the trachea. Okay, so I can see that these lesions are sub-centimeter in size. There is no associated
This
parenchyma.
this nodular opacities in the lung, specific for something?
Having them in the periphery, a few differential diagnoses are there. One of them is septic emboli. Other differentials are pulmonary AVMs, telangiectasias, metastatic
Any
deposits. Yeah.
any zonal predominance for these lesions?
Yes, they are more predominant in the upper lobes. However, I could see also some of them in
Can
the
you look
middle
at the
and upper
fissures?
lobes.
Can you look at the fissures of the lung?
At what, sir?
Fissures.
Fissures. Okay. Hmm. The fissures aren't thickened and
Okay.
they look normal, yeah.
Can you give me your final diagnosis for this case?
Collectively, since the patient has multiple mediastinal lymph nodes and multiple pulmonary nodules, I would primarily suspect a infectious etiology. Septic emboli are at the top of my differential diagnoses. Other differential diagnoses in this case are other atypical infections like tuberculosis.
Okay, thank you.
Thank you.
Leave the mouse, please. Leave the mouse. Okay, you started the case very well. Okay. You described the plain radiograph. Very good. There is bilateral patch opacities, predominant along the both upper lung zones, upper and mid, relatively sparing lung bases. Second, right paratracheal stripe, some sort of prominent hyla. You commented on the bony skeleton of the chest, no any retraction, no pneumothorax, no pleural effusion. So, as a clinical reasoning of this patient, you put pulmonary contusion or maybe laceration, maybe aspiration also. The other may be this incidental finding. You can see here mediastinum is widened, as you told, maybe mediastinal hematoma, but you can see here the aorta is seen well, the heart is good. So we can think in incidental disease. If you found thickened right paratracheal stripe, multiple confluent patchy opacities of the lungs, predominant at the upper lung zone and the mid zones, relatively sparing the lower lung zones. Without trauma, what are you suspecting? You told sarcoidosis, okay? Candidate one?
Yes, Yes, sir. Sarcoidosis is
You-
not differential. Yes.
Yes. Um, it was very good to put sarcoidosis, but after you saw the, the CT, you have to tell me that it is sarcoid case. Right paratracheal lymph node, pretracheal, subcarinal, bilateral hilar, and there is patchy opacity. Do you know the stages of sarcoidosis?
Yes, in stage 0, it's normal chest X-ray. Stage 1 is bilateral hilar lymphadenopathy. Stage
Okay.
2, super added pulmonary nodules. Stage 3, pulmonary
Okay.
nodules without
Do you know
lymphadenopathy.
what
Yeah.
is the features of pulmonary nodules of sarcoidosis?
Yes, usually they are very pericovascular in distribution, and I couldn't
Okay.
really link that in the images, so that I excluded them after seeing the CT scan.
Can you see the fissure here?
Yeah, yeah,
Very
yes, in these
fissural,
images.
very fissural,
Mhm.
very bronchovascular. Is galaxy sign. You know the galaxy
Mhm.
sign?
Yes.
This one. Okay. Here, here, everywhere. Okay. You bought septic emboli. Why did you bought septic emboli in this patient? Patient trauma, no fever, no cavitation. Okay. So septic emboli is cavitary lesion and the patient feverish. So as in this case, no differential for sarcoid. If you want to put a differential, you will put lymphoma. Okay. Uh, lymphangitis carcinomatosis. Okay. Okay. How will you manage the case of sarcoid?
Yes, first I will review the previous images
Okay.
and compare with the current one, and I will refer the patient for respiratory team and MDT discussion, as well as recommend ACE and calcium levels measurement.
Okay. Any nuclear scan could detect the
Yes,
sarcoidosis?
gallium scan.
Okay. Gallium dotatate. What is the
Yes,
signs of nuclear scan will you see in
it's called
patient of sarcoid?
gamma psi. I'm not sure. It's gamma or
Lambda
delta
sign
psi.
and
Lambda psi. Yes.
the Garland thyroid. Okay.
Yeah.
Bilateral hilar lymphadenopathy, right paratracheal lymph node.
Yep.
What is the treatment for sarcoid?
No, steroidal treatment.
Okay. Steroid therapy. Patient
Steroid
may
therapy.
need transbronchial biopsy of the lymph nodes for confirmation of the sarcoidosis. Okay.
Right.
Thank you, Candidate 1.
Thank you.
Candidate 2.
Yes. Yeah.
Assalamu alaikum.
عليكم السلام ورحمة الله وبركاته.
Dr. Sameh.
ازيك يا دكتور
Okay.
منير؟ الحمد لله.
We'll review the control. Can you ask for the remote control, Dr. Sameh?
اوكي.
Okay. Your patient is 50 years old, male patient with progressive dyspnea. I
اوكي.
want to show you the, please, X-ray first. Okay. You can start.
Okay. So I'm presented by frontal chest radiograph of 50 years old male patient with progressive dyspnea. There is evidence of silhouetting of the right cardiac border by large soft tissue mass lesion seen occupying most of the right hemisthorax. No evidence of pleural effusion. There is also calcifications, batch of calcification seen overlying this soft tissue shadow. The periphery of the right hemisthorax also showing nodular thickening. Could be this is pleural thickening. There's also undulated right hemi diaphragmatic surface at the right side. The left side There is a subtle opacity seen at the basal zones. However, the most of the left
Okay,
hemispherics looks normal.
so we are dealing with a mass rising from mediastinum or the lung or the bone or the pleura.
Yeah, this silhouetting of the right cardiac border suggesting this mass is originating from the anterior mediastinal, mainly anterior mediastinal mass.
Okay,
The
so what's
thickening,
your differential?
yes, the thickening of the periphery also could be due to pleural thickening. The confluence of findings could put the differentials like mass at the pleural and mediastinal surfaces of at the peripheral and mediastinal pleural surfaces or pleural lesions related to anterior mediastinal mass. The differentials in this age group, I will put thymic tumor in the first of my differentials. Uh, thymic tumor with pleural metastasis. The other differential, which is less likely, could be mesothelioma. However, this calcification could change my mind slightly, as this calcification could be related to pleural plaques associated with asbestos, and the whole thickening
Okay,
is
so
mesothelioma. So my differentials in this case is mesothelioma and thymic tumors.
okay, what will you do next for this
I
case?
will recommend CT with contrast and the checking.
Where is the ST? You have the control, you can.
Yes.
No, just click and by your trackball.
Yes, I am tracking by the arrows now. So this is a large anterior mediastinal mass lesion with central calcifications. Uh, this is the last image. I can see in the last image I can see there is hypodense lesion in the right lobe of the liver. Uh, I will scroll up. There is also thickening of the pleura, posterior pleura, nodular thickening, and also in the fissures there is soft tissue thickening. Scrolling up through this images, this is I think this is the last slice of this image. So in my mind, will put a thymic tumor as a
Can you
first
describe more
differential.
the region, please?
This is anterior mediastinal soft tissue mass lesion with central calcification. This mass lesion seen compromising the right main bronchus and the mediastinal structures to the other side, to the left side. There is no evidence of, I'm checking for any evidence of vascular invasion. Uh, I couldn't see any vascular invasion from this mass. Mm. However, here I couldn't elicit the superior vena cava. I'm searching for it.
Okay, so
Yeah. Uh, I couldn't see the superior vena cava, so it could be infiltrated by this mass lesion. My first diagnosis for this case is malignant thymic tumor with pleural metastasis and also hepatic metastasis with likely invasion of the superior vena cava. I will check in the other reconstructed images, coronal and sagittal, to confirm this, and also change the window to the bone window to assess for any bony metastasis in the coronal image. There is no opacification of the superior vena cava, so it is likely infiltrated by this mass lesion. This patient needs urgent transfer to the cardiothoracic team for insertion of superior vena cava stent. And also this should be discussed at the cardiothoracic oncology MDT meeting for possible biopsy and CT chest, abdomen, and pelvis to complete the metastatic workup of the patient.
Okay, thank you.
Welcome.
Some notes on here on the plain radiograph. We are dealing with mediastinal lesion. You can see the outer border of the lesion, but we couldn't see the medial border of the lesion. Also, the lesion is very large, but we can put our priority here for mediastinal lesion. There is some coarse calcification. You did very well when you mentioned some pleural nodules here, but no other any pleural calcification or peripheral denoting asbestosis. So it is likely to be mediastinal mass. We couldn't see the right heart border, so it is likely to be anterior mediastinal mass. However, pleural mass couldn't be excluded. Also, lung lesion couldn't be excluded because the mass is large. Okay. If you want to put a differential, as you told, we can put antemediastinal mass with calcification. So will be thymic tumor our first possibility. Against lung, and less likely to be lung lesion because of course calcification. Pleural also rare to be calcified lesion. So the CT here confirms the presence of the mass anterior mediastinum, but you have to search for the complication of the lesion. Okay, and if you the examiner give you the CT, don't go for other finding here in the liver here. No. You have to start with the lesion itself. Okay. You have to start the lesion, macrolobulated large lesion invading the mediastinum. I couldn't see the IBC, so it is invaded by the lesion. The lesion is seen extending here to the right atrium also, compressing the right main bronchus. So we have to call this. There is also multiple enlarged lymph node here along the mediastinum and the epiphrenic pericardial, and also here in the axilla, and there is multiple nodules here. So you have to go through the region like this. Okay, don't go for not main finding before the main finding itself. And you have to tell the examiner, as the invasion of IBC, it is an emergency. I have to urgently inform the referring physician and urgently refer the patient to cardiothoracic team to tell the examiner that you are a safe radiologist. Okay. For this lesion, okay, as you told, maybe lung lesion less likely because of course calcification. Pleural, maybe malignant pleural fibroma, but less likely. The most likely diagnosis here to be mediastinal tumor, not lymphoma because it's not like lymphadenopathy, not thyroid because not extending to the neck, not teratoma because of the age of the patient. The patient is 50. So our first possibility here will be thymic tumor. Thymic tumor, as you told, it is not benign, so it is malignant thymic tumor, which may be malignant thymic carcinoma, and of course this patient is metastatic malignant thymic carcinoma. Okay. Thank you, Dr. Sameh.
Thank you.
Well done. Next candidate.
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته. Okay. Your patient, 50 years old, male patient, complaining of chest pain weight loss, and chronic cough.
So I'm presented with the frontal chest X-ray of a 50 years old patient presented with chronic cough and chest pain. I can see bilateral reticular opacities, reticulonodular opacities involving both lung fields, more in the lower lung zones. The
More at the
right
lower.
heart more in the lower, more in the mid and lower lung zones, and central, more central and in the mid and lower lung zones. And the right heart border is also obscured. There's a retraction of the right hilum slightly upwards. Both costophrenic angles are free. The cardiac size is within the normal range, and the scanned bones show no obvious abnormality. So I'm considering interstitial lung disease because of this reticulonodular
Can you show me?
Sorry?
I'll give you the. Can you ask? I will give you the remote. Can you ask for the remote control?
Yes, of course.
Okay.
Okay, I have the remote.
Okay.
Okay.
Approved. Okay. Show us where is the nodular opacity. Do you see?
I said reticulonodular opacities. I feel like nodules with reticulations here.
Mainly
Nodules.
coarse
Those
reticulation.
also.
We couldn't see nodules.
I thought these are like nodules. I don't know. Okay.
Which one? I
Okay.
couldn't see your mouse.
You couldn't see my mouse?
Click
Like
once.
this. Click once. Okay. So
Okay.
this nodules, this small
All
nodules
this.
together
Okay.
with the
All.
reticulations.
Okay. You are
And
dealing
also
with
here peripheral.
coarse reticular opacities. Okay.
Okay. Okay.
Okay. What
So
about the lung volume?
the lung volumes are preserved.
Okay.
Okay.
So zonal predominance.
Central, and so it's mainly these reticulations are mainly
You
central
told
and mid and lower zones. Yes, this is what I said.
you told the sparing costophrenic angle. Yes.
No, I said costophrenic angles are free. I didn't say sparing costophrenic.
Sparing. Yes.
Yes, I said
Okay.
they are free, but yes, I meant no pleural effusion. This is what I meant.
Okay.
Okay.
So, what's your differential for this imaging finding?
So I'm thinking of interstitial lung disease because of this
Like what?
coarse reticulation. So it will depend like on the history of the patient, but
What?
it can.
Like which interstitial lung disease are you suspecting?
So because of this lower zonal predominance, it could be non-specific interstitial pneumonia, or also usual interstitial pneumonia.
Is
Maybe it's
UIP will preserve the lung volumes?
no.
Okay.
It's usually decreased lung volumes.
It will spare the
Also,
costophrenic angle?
I don't know. I'll say.
Okay.
I don't think it will spare. It will be involved also.
Yes. So, anything
Maybe also
else?
the patient, if has like any previous history of collagen vascular disease also.
No collagen vascular disease.
No collagen
Patient
vascular
is
disease.
complaining
Any
of chest
history,
pain.
chest
Any
pain.
reasoning for this chest pain, please?
Chest pain. I'm not sure, sorry.
Okay.
I'm not sure
What
if
will you do next for this patient?
maybe chest pain. Is he on any like chronic medication for any like cardiac condition?
No problem.
Like
What will
okay.
you do next for this patient?
So high resolution CT.
Okay. Here is a
Okay.
HRCT.
Okay. I shall request control again.
Control is with you. You can click once and scroll.
I'm just not, oh, okay.
You are scrolling.
Just lagging, yes.
No problem. Take your time.
Sorry for that. Skip. So, presented with high resolution CT, now the resolution of the same patient, axial cuts, long window. I can see, I will scroll till the last cut and then start presenting my findings. So, both lung fields are involved by multiple reticulations, as I said before, but also cystic spaces involving both lung fields. Also with architecture distortion, multiple peripheral like emphysematous bulli are also seen mainly within the left lung. So about the zonal predominance, I previously mentioned in the chest X-ray. I think I would like to retract my statement because now I can see the upper zones are also severely involved by this lung disease. The cardiac size is within normal.
Okay.
There is a rim of left pleural effusion as well.
So we are dealing with
Cystic lung disease.
okay.
So I would like to
What's
ask
this?
about the patient history of smoking. If the patient is a
Okay.
smoker, I would be with Langerhans cell histiocytosis.
Okay.
Also because the patient is male, the other cystic lung disease as lymphangioliomatosis is more in females. So I think the most probable diagnosis of this is Langerhans cell histiocytosis. I would refer these findings to the referring clinician, and this patient will be discussed at the
Do you know
seen
what
referred
other
to respiratory clinic. Yes.
do you know what other disease related to smoking? Chest disease.
So I think this also chronic obstructive lung disease, pulmonary lung disease, such as emphysema, and this patient has emphysema. And
Okay. This
also
patient.
desquamative.
Okay.
Yes,
This
desquamative
patient
interstitial
is
pneumonia.
complaining of chest pain.
Mm.
Do you have anything reasoning this chest pain?
I would like to check the the mediastinal window to check, but it will be like because it's a non-contrast
Okay, thank you.
result. Okay.
Leave the room.
Yeah.
Here,
Yeah.
plain radiograph, there is coarse trabecular pattern
Mm.
here. But can you look here at the edge of the film? Here, can you see anything here?
It means like a small rim of pneumothorax,
Yes,
because I thought it's like contained septations in the CT, so I thought it's like
yes.
emphysema, not
Okay, we will
pneumothorax.
go for, we will come to CT, okay?
Okay.
But first of all,
Mm.
in every patient, you have to look for safety points,
Okay.
which include pneumothorax, especially in some cystic lung disease like cystic fibrosis, LCH, PCP, anything like this you have to exclude because you know that if you missed pneumothorax, what will happen?
Yes, it's a safety point. Yes, it's the
Okay,
case.
yes. So there is rim of pneumothorax, okay? And
Mm.
at an emergency, I have to inform the referring physician, keep the patient under observation, patient follow up, may need intercostal tube, okay? Come
Mm.
to the lung course trabecular, but you can see there is sparing of the costophrenic angle, and here also lower lung zone. So,
Mm.
and also preserved lung volumes, which exclude UIP.
Interstitial lung disease. Mm.
Yes.
Mm.
So we are dealing with coarse trabeculation.
Mm.
We can put maybe cystic lung disease, maybe also sarcoid. So you have to put this in your mind. Then you ask for the CT.
Okay.
CT, I give you the CT Anything else will be, this is the lung edge.
Mm.
Okay, there is some
Yes, this is what I.
reticulate. Yes, which means this may be recurrent or chronic pneumothorax. Okay,
Yes, I didn't
but
think of this. Yes.
yes, but yeah, it is localized to the left lung. If you go here also, evident here.
Mm.
Here.
Yes.
So it is against and the lung edge you can see. So
Mm.
it is pneumothorax. These features of cystic lung is called bizarre
Bizarre
shaped.
shaped nodules.
Yes.
Mm.
So if you saw bizarre shaped cyst, upper lobar or upper zonal predominant, you have to look for nodules. Okay, and as you told, you have to ask for the patient history of smoking. Okay, it is very good point from you to. I will ask for the patient smoker or not. There is nodules here, small nodules here, and if you go down, there is some also peripheral nodules here. So we are dealing with a case of LCH. Okay,
System. Yes. And
complication of
about
LCH. Yes, yes,
so the chest pain was due to pneumothorax.
yes, of course.
Okay. Thank you,
Okay,
sir.
so you have to tell bizarre shaped means irregular, not uniform, not spherical. Okay. Stages. Do you know the stages of LCH?
No, unfortunately not.
Yes, yes. LCH will start as a centrilobular nodules. This
Yes, you
nodule,
mean so this is the staging system. Yes. We'll
yes,
start
yes,
and then nodules and then cavitation occurs
yes,
and it's a cyst.
cavitation and then
Yes, a
transform
cyst.
to cyst. What is the difference between LCH and LAM?
So LAM is the cysts are more uniform
Yes,
and likely no nodules will occur.
yes,
Also, it's more common in female.
okay,
So it's not directly related to smoking as
yes,
Langerhans cell histiocytosis also. And
yes.
patient may have history of another like syndromatic in LAM like von Hippel-Lindau.
Fibrous sclerosis.
Yes.
Okay.
Sorry, yes, tuberculosis.
Okay. Smoking related disease like LCH, DIP,
Yes.
respiratory bronchitis. Okay.
Yes. Okay. Okay. Thank you, sir.
Thank you so much.
Thank you, sir.
Next panel. And four.
السلام عليكم.
عليكم السلام ورحمة الله وبركاته. Your patient is adult male, history of smoking, presented with fever.
I am presented with the chest radiograph of a skeletally mature patient. I can see a cavitary lesion in the right middle lung zone. Also a small nodule in the right lower lung zone. No other cavitation can be identified. I can see also surgical emphysema related to the left side hemithorax, lower part of left side hemithorax. Cardiac size is unremarkable, no pneumothorax, no pleural effusion. The bone is unremarkable, but in my daily practice, I want to check the bone and make zooming on the left side at side of the surgical emphysema. No erosion in the bone can be seen, and no bony fracture identified. To summarize case, this case with a small nodule at the right lower lung zone and cavitary lesion in the middle lung zone, right, with emphysema seen in the left hemithorax. No other finding. In patient complaining of fever, maybe this one septic emboli and the subcutaneous abscess formation. I want to ask about if patient drug abuse and any previous history.
Okay.
I will convey my finding to referring physician and request CT with IV contrast to confirm his diagnosis.
Here is the
Sorry,
CT. Can
doctor.
you ask for the remote control?
I am sorry. Can you scroll for me?
Okay, I will scroll for you this time. But for any
Okay.
candidate, please, you have to be ready for scrolling every case, okay? Because this will happen in the exam. No one will scroll for you, okay?
Okay, thank you. I am presented with the CT long window for the same patient. I can see multiple air foci in the subcutaneous, paravertebral, and posterior part of the chest wall, also lateral aspect of the left hemisthorax, with the loculation seen. Also, I can see multiple nodules more prominent in the right lower lung lobe. Multiple cavitary lesion also seen in the right hemisthorax. No pneumothorax can be identified. Minimal pleural effusion seen in the right side. So this case with multiple cavitary lesion and nodules more prominent in the right lower lobe with the mild pleural effusion and the multiple subcutaneous collection with air foci. In my daily practice, I want to check mediastinal window to see if any associated lymph node and the bone window. The mediastinal window for the same patient, axial cut with the IV contrast. I can see the collection in the subcutaneous posterior aspect and the lateral chest wall associated with the peripheral contrast enhancement. Peripheral contrast enhancement and multiple air foci and confirm presence of minimal to mild pleural effusion with associated underlying minimal lung collapse. The spleen is enlarged, the splenomegaly, and
Okay.
there is
Can you give me your
also
final diagnosis and management steps?
this case of septic emboli associated with the subcutaneous collection abscess. Urgently, I will convey my finding to referring physician and start IV antibiotic and the drainage of the abscess and discuss case in thoracic MDT.
Okay. What the other differential of cavitary lung lesions, multiple cavitary lung?
Maybe Wagner granulomatosis or multiple cavitary metastasis or primary cavitary lesion. Sometimes this cavitation, if upper lobe predominant, TB is the one of the differential diagnosis.
Okay. Do you know the organisms which could cause cavitation of infection?
Again, please, sorry.
Organism that can cause cavitations, lung infection.
TB, one of causes, maybe staph.
Okay. Thank you. Well done. Just some notes on your description, please. Yani don't in VIVA or long cases, don't go for the spotter. Don't tell spotters. I can see a cavity. Okay, you have to tell there is rounded opacity seen in the right middle lung zone. I can see there is some central lucency, which means it is cavitary lung lesions. I can see also there is multiple nodular opacity seen within the right lower lung zone and the slightly left lower lung zone. Okay, I can see there is thickening of the soft tissue along the lateral chest wall on the left side. It shows central lucency, which can be gas loculi inside. Okay, as a patient presented with fever and history of smoking, I can suspect this subcutaneous abscess and the multiple cavitary lesion in the lung fields, which may be septic emboli. I correlate with the patient history, previous imaging, clinical data, inflammatory markers, and I will advise urgent CT with contrast for better characterization. Okay, and just you know everything good, but you have to show your approach to the examiner. Okay.
Okay.
So second thing in CT, okay, because you are not scrolling, but no problem. Okay, it confirms the presence of cavitar lung lesions. It confirms the presence of large subcutaneous, large collection along the lateral abdominal chest wall on the left side, extending posteriorly. Okay, I can see here
Okay.
also there is multiple nodular opacities with stream butt appearance.
Green bot.
Yes, and the peribronchial thickening. Okay, which means there may be two methods of infection. Maybe hematogenous spread from the chest wall abscess, and endobronchial spread from the other cavitary lung lesions. Okay, so it is a case of
Okay.
septic emboli. Okay, it is an emergency, as you told, for drainage of the abscess and also for empirical antibiotic. Okay, what could be other sources of septic emboli in patients?
Other than hematogenous and endobronchial?
Yes, yes. Maybe hematogenous also, but what other sources? If you saw septic emboli, what are you thinking about? If no abscess here, what are you thinking about?
Maybe lymphatics or hematogenous?
Yes, hematogenous, you have to suspect also infective endocarditis. By the way, it is a common exam case to present with infective endocarditis and septic emboli. Okay, so
Okay.
patient may need another patient. If you face the patient with infective endocarditis, you have to urgently refer the patient to cardiology team. Okay, this patient did follow up and now resolved it. Okay.
Improve.
Yes.
The patient
About
showed improvement and resolution of the nodule and cavitary lesion, also the abscess.
yes. About the organisms that can cause cavitation, Klebsiella and Pseudomonas. Okay.
Okay.
Thank you so much.
Thank you for you. Thank you.
Welcome. Next one.
Yes, good evening, doctor.
Okay, your patient, 45 years old male patient with progressive shortness of breath.
Okay, this is a frontal chest radiograph of an adult patient, where I can see that there are bilateral upper and mid-zone reticular thickening, with then left upper zone opacity, soft tissue opacity. There's also loss of volume on the left hemithorax, with an elevation of the left hemidiaphragm, no pleural effusions, and the bones looks normal. The cardiac contour is with the normal limits, and no hilar lymphadenopathy or hilar enlargement. So in conclusion, this is in bilateral reticulations with loss of volume. I'm thinking of a fibrosis, underlying fibrosis, with impression of an left upper lobe mass. I would review the previous images of the patient, and I will recommend a CT with the contrast for this patient.
Okay, can you ask for the remote control?
Yes. Okay.
Okay, approved. You can scroll.
Thank you. Sorry.
Click once and scroll.
Okay.
Scroll by your arrows
By the
or
by the arrows.
forward.
Okay. All right. Okay. Yeah. Okay, this is presented with CT chest with contrast lung window. There are bilateral upper lobes, mass-like opacity with consolidation, dense consolidations, reticulations with a I think a bronchiectasis or traction bronchiectasis. There is architectural distortion bilaterally as well. Okay, I'll just go through all of the images. Okay, there are ground glass opacities seen in the lower lobes bilaterally. However, there are no evidence of fibrosis so far seen in the lower lobes. It is marked on the upper lobes bilaterally. I'd like to look at the mediastinal window to check for lymph nodes. Okay.
Click once.
Okay. I'll just go to the bottom of the image. All right. The uppercuts of the abdomen in a quick look looks unremarkable. Okay. There are few enlarged lymph nodes seen in the aortopulmonary window, subcarinal, and the pericardiac region.
Okay.
So in summary, I think I'm dealing with bilateral upper lobe fibrosis. I think this is progressive massive fibrosis with enlarged lymphadenopathy. This could be, I reviewed, I didn't notice any pleural plaques and no calcified lymph nodes to suggest silicosis. However, I will review the occupational history of the patient, and else it could be due to sarcoidosis. So I will discuss it in the chest MDT with the review of the previous images of the patient if available and the occupational history of the patient. If there is no occupational history, then I will recommend an ACE calcium level for this patient and biopsy.
Okay, thank you. Okay, for the chest radiograph, we have bilateral upper mid-zone multiple nodular opacities. Okay, sparing slightly the lung bases. There is tinting of the left hemidiaphragm, which suggests fibrosis of the upper lobe. Both hila are balled up, which also suggests the fibrosis. Okay. So we have fibrotic changes in the lungs. Okay. If we look at the right paratracheal stripe, it is slightly thickened, and there may be also here some opacity. Okay. So we have upper lobe fibrosis, loss of lung volume, and lymphadenopathy. We have two differential, silicosis and sarcoidosis. Okay. We went for the CT. Okay. CT confirms the architectural distortion of the lung, some tracheal traction, tracheal dilatation, some air trapping, down groundedness, pacification. We look at the carina of the coronal, we will see the carina will be splayed. Okay, confirm the presence of upper lobe fibrosis. Okay, we have two differentials, as you told, silicosis and sarcoidosis. One of them, we have to ask for the patient occupational history. Second thing, we have to search for any other sign. If you look here at this lymph node, you can see there is peripheral calcification. Okay, so it may be eggshell calcification. Um, and also, so the final diagnosis will be progressive massive fibrosis, mostly due to silicosis. We couldn't see any peripheral nodules like this.
Yes.
There are pictures of sarcoidosis.
Mhm.
So we have to put the possibility of silicosis first. But if you put sarcoid, no problem, we will not lose. Okay.
Okay.
Thank you. Well done.
Thank you.
Next one.
السلام عليكم
يعني
سير.
عليكم السلام ورحمة الله وبركاته. Okay, you have 50 years old male patient with few months of progressive dyspnea and cough. Can you ask for the remote control?
Okay.
Okay, approved. You can scroll. Click once and scroll.
Okay. Now I have been presented with CT chest, non-contrast, axial cuts showing. Now I'm checking the mediastinal window. The mediastinum vessel looks intact. No abnormality in the vessels, nor the heart. Scrolling down. No abnormalities detected in the mediastinal windows. However, some reticular opacities are seen peripherally in both lung fields. And there's a cystic lesion closely related to posterior aspect of the trachea.
Okay, so
So I need to check the lung window for
okay, here is the lung
assessment
window.
of the- Okay, now I'm presented with the lung window for the same patient. There is diffuse ground glass opacities in both lung fields. It's peripheral predominance with a reticular interstitial thickening, causing the curvy beefing appearance. It's seen affecting in the lung upper and as well as lower lung fields.
Okay, so we have ground glass infiltration with interlobular septal thickening. What's your differential?
The first differential would be alveolar proteinosis. However, other differentials as pneumonia could be a possibility. Pulmonary hemorrhage could
Which
be a
type of
possibility.
pneumonia will cause these features?
No idea.
Okay. Anything else?
Pulmonary edema, but less likely to be pulmonary edema.
Why?
No central predominance, no cardiac enlargement, no pleural effusion. So I'm
Okay.
excluding pulmonary cardiogenic edema.
Okay. Anything else?
Regarding the bones, I can detect any abnormality in the bones.
Ignore about the
Liver.
bone. We are talking about the
Okay.
chest changes. Any other differential?
Maybe interstitial lung disease.
Okay, good. So your first diagnosis will be?
Alveolar proteinosis.
Okay. What's your management steps?
I would refer the patients for the respiratory team for pulmonary function test and laboratory findings to exclude any inflammatory marker raising.
Is it a chronic process or acute process? Pulmonary alveolar proteinosis.
I think chronic.
Okay. So what are you expecting? Inflammatory markers will be high or low?
Regarding alveolar proteinosis, it will be low. I mean
Okay.
the blood to exclude the pneumonic cause, the
Okay.
infectious pneumonic cause.
Any specific management for pulmonary alveolar proteinosis? Okay, no problem.
Management? No idea.
No problem. No problem. Okay, this case it is the antimony case. Okay, it is ground glass opacification, geographic pattern, sparing some secondary pulmonary lobules with interlobular septal thickening. Okay, mediastinum is good, nothing within the mediastinum. So we are dealing with a case of chronic ground glass opacification with interlobular septal thickening. If you want to put a differential, if this case is acute, you have to put pulmonary edema, ARDS, pulmonary infection, or pulmonary hemorrhage. If the patient is chronic, we have pulmonary alveolar proteinosis, interstitial lung disease like organizing pneumonia or hypersensitivity pneumonitis, or maybe adenocarcinoma or bronchoalveolar carcinoma. Okay.
Okay.
For pulmonary alveolar proteinosis, it is 95% autoimmune disease. Okay, they can give immunosuppression. For the diagnostic and the treatment, we do bronchoalveolar lavage, which will be diagnostic and therapeutic. Okay.
Okay.
So you have to know these steps of management and also the differential diagnosis. There is more differential, maybe in SIP, DIP, LIP. All this may come with ground glass opacification and interlobular septal thickening. They told that which is specific for alveolar proteinosis, you can see well-defined sparing of secondary pulmonary lobules here. There is involvement and well-defined sparing, okay, of the other secondary pulmonary lobules. Okay, thank you.
Thank you, sir.
Welcome. Candidate 7, leave the mouse, please.
Yes.
And 6.
I'm here, yes. Assalamu alaikum.
Okay, I can start now. Your case, 70 years old female patient, resected bladder cancer on surveillance to rule out metastases.
Okay. This is the chest X-ray frontal projection of 70-year-old female patient who is a case of bladder cancer with suspected mets. I'm looking that there is the first at the lungs. The most striking abnormality which I can appreciate is the slight widening of the right paratracheal region, and as well as bulky right hilar region. I'm looking at the lungs. The lungs epiphysis appears normal. I'm comparing the both lungs. However, there is mild cystic increased hyperlucency in the bilateral upper lobes. However, the bilateral, I can appreciate that there is suspicion of an opacity in the right costophrenic angle. However, it appears it could be projectional. The retrocardiac area, I have a suspicion of a nodule in the retrocardiac area. Also, there is no evidence of any pneumothorax or pneumomediastinum on this imaging. The aortic knuckle appears normal. Bilateral breast shadows also appear normal. Now I'm looking at the bones. The bones, visualized bones appears normal. So I'm suspecting an opacity in the retrocardiac area, left retrocardiac area, as well as a nodular opacity in the right paratracheal region, which along with bulky right hilum. So I will further advise CT chest with contrast.
What are you suspecting?
I'm suspecting, as the patient is known case of bladder cancer, I'm suspecting that this nodule could be metastatic in the retrocardiac area, as well as
Can you
with
show,
the,
can you ask for the remote control?
yes. I have requested.
Okay, approved. Show me, click once and show me the nodule in the retrocardiac region.
Here this area,
Click once.
this area.
Yes. Clear. It's clear area. Nothing. This is a rib. Okay.
Oh,
Ignore about this. So you are
sorry.
suspecting this. Ignore about this. Nothing.
Okay, okay.
So you are suspecting right paratracheal lesion. Yes.
Yes, I am
Okay.
along with.
Okay. You can scroll. Click once and scroll through the seated chest.
Okay. So should I request for control?
No. You are scrolling.
Okay. This is the CT chest. A lung window in which I can appreciate there is a mild apical pleural thickening on left side. There is a ground glass opacity in the right paratracheal region. There is a soft tissue nodule opacity in the right paratracheal region with surrounding ground glass. And this opacity, as well as I can also appreciate few ground glass opacity air infiltrates in the right upper lobe. So I'm going down to look any other opacity. I will scroll down the images. There is no evidence of any pleural effusion or any other nodule in the lungs. So I will also want to see that nodule in the right paratracheal, soft tissue mass in the right paratracheal region in on the mediastinal window. So on mediastinal window, I can. Sorry, I am not.
Click once.
Scrolling.
Yes.
Yes, I have.
You are scrolling.
So there is a soft tissue mass in the right paratracheal region, closely abutting the trachea, and as well as I am looking for the relationship of this mass with any other vessels, which I cannot appreciate. There are few small lymph nodes, mediastinal.
Okay. So give me
So-
your final diagnosis, your management
So,
step.
so as this is a patient of the bladder cancer, I'm suspecting it as a metastatic deposit. I will advise bronchoscopy.
Okay, will
biopsy
the
formation
metastatic deposit will come
because the patient is known case of bladder cancer. However, it could be an infective disease process that there is a peripheral ground glass haze, if the patient is taking any immunosuppressive, then it could be
anything else other than metastases?
As this mass has irregular margins.
Okay.
So if the patient has
Can you describe more this mass? Can you describe more for me, please?
this
Here's the
mass,
crown.
yes, this mass is having
So-
irregular
yes.
margin with surrounding ground glass opacity, giving a halo.
Do you know the most suspicious pulmonary nodules to be malignant? The features of pulmonary nodules. If you saw a pulmonary nodule, what are the features make you highly suspecting this malignant nodule? Candidate 7. I couldn't hear you, Candidate 7. Candidate 7. I think we lost candidate 7. Okay, we will go for the next candidate till candidate 7 come again. Okay, candidate 8.
Good evening, sir.
Good evening, how are you? Your patient, I want to give you the chest radiograph first. 65 years old female patient with ruptured Achilles tendon and shortness of breath.
Okay, this is a frontal chest radiograph of 65-year female patient who presented with Achilles tendon rupture and the shortness of breath. This is frontal radiograph, so I can look at the images first. The lungs looks normal and cardiomediastinal contours are normal. I can see there is a tetracardiac opacity with air fluid level inconsistent with hiatus hernia.
Okay, good.
And I don't see any significant bony lesions. So in this radiograph, looks normal for me. And
Okay.
but even patient presented with shortness of breath and recent history of Achilles tendon rupture, I would like to go with CT pulmonary angiogram to exclude.
Okay. You can ask for the remote control. Candidate 7, we will come to you back after candidate 8, okay?
I requested, sir.
Okay. Click once on the score.
Yeah. So these are the axial images of CT pulmonary angiogram. I can see there are extensive filling defects in the both main pulmonary arteries, and I also could see in the aortic arch as well. So I'm looking at the heart, whether there is any septal defect or aortic thrombus, cardiac thrombus. There are extensive pulmonary emboli. I'm looking at the aorta to see whether there is any dissection. Aortic ascending aorta looks normal.
Okay. So?
Yeah, I cannot explain why the thrombus in the aorta, but there is extensive pulmonary emboli.
What could be the cause? You found pulmonary emboli, aortic emboli, patient complaining of rupture Achilles tendon, female patient 65, shortness of breath.
Is it
You have to put a clinical scenario for this patient.
I can't see any fat within this. Sometimes.
Okay.
Yeah, it could be.
If you found, okay, you can talk, no problem. Okay, if you found pulmonary emboli and aortic emboli, can you explain this?
It could be somewhere else, the thrombus, but I couldn't see anything within the heart. I'm looking whether there is any down. Can't see anything. I can't imagine what the correlation.
Okay. How will you manage this case?
Yeah, this is acute because extensive pulmonary emboli and also aortic emboli is more risk for embolization, systemic embolization. So I'll give my findings to the referral clinician. This patient need to be seen by test and hematological people to manage the pulmonary emboli.
Okay, thank you. Here, as regarding the plain radiograph, only we can see the hiatus hernia, otherwise aortic knuckle is well, hilar shadow is good, lung feels good, so like to be normal as you told. We have patient complaining of shortness of breath, old age, query rupture Achilles tendon. We did CT with contrast for pulmonary, researching for pulmonary emboli. We found the pulmonary emboli. Till now, everything is very good. If you found pulmonary emboli, what are you searching for? Other than ignore now the aortic emboli.
Yes, I'm looking for the complications of pulmonary emboli, whether there
Which,
is any right ventricular strain.
okay, any heart strain here?
Mm. Yes, I think the interceptum is a strain, and also I
Yes, there
can
is
see.
bound
Yeah.
of the interventricular septum, which you have to comment on this point, please. Okay. Okay, no problem. Leave the mouse. No problem. So we can see emboli within the pulmonary and on the systemic circulation, which is called paradoxical impulse. So there should be right to left shunt. Okay. So you have to tell the examiner, I am searching for any connection between right side and left side. Okay. Here, because this study is not ECG gated, so there is more motion artifact here. Okay. But after that, the patient did echocardiography and diagnosed patent foramen ovale. We have to go for the pulmonary, the aortic impulse. Okay, you see it here, but you didn't go up to see where is the extension.
Carotid.
Left.
Left carotid artery.
Left subclavian.
Sorry, left carotid.
Left subclavian artery. And maybe go for the lower limb and cause severe lower limb pain and lower limb ischemia, which is ruptured Achilles tendon, is a suspicious, but it is not the case. Okay. There is also here small paravertebral cyst, incidental finding, likely bronchogenic cyst. What could be the connection between right and left? Maybe patent foramen ovale, maybe ASD, maybe patent ductus arteriosus. We have to ask for the sagittal, but we couldn't see anything in the sagittal. Okay, so this case is urgent. You have to refer the patient to cardiology team and medical team for thrombolytic therapy and for further assessment of the heart. Okay. Thank you so much. Well done.
Thank you. Thank you very much.
Candidate 7, are you with
Yes,
us?
I am. Yes, yes,
Okay.
I am.
Okay. Okay. Welcome. So, what is the most important features could be red flag for nodules in the lung to be malignant?
For malignancy, for in this patient, if if there are multiple lesions, then likely they will be more suspicious for metastasis, malignancy.
Okay.
And,
For the solitary pulmonary nodules or pulmonary nodules, if it is solid, okay, it is suspicious. Okay.
Yes.
Ground glass suspicious, but if it is mixed, it is highly suspicious to be malignant nodules. Okay.
Okay.
So this nodule here, there is mixed density,
Yes.
ground glass and soft tissue density, and there is another ground glass, another ground glass here, and there is infiltration here, here. Do you think the metastasis will be like this? Ground glass nodule
Yes, ground glass nodules can be metastasis.
family. Okay,
But they
but not. Yes.
But there can these can be metastatic, but they need biopsy because there are other possibilities like angioinvasive aspergillosis. Wait a second.
Okay. Anything else?
So there was other possibility of angioinvasive. If the patient is immunocompromised, there can be possibility of angioinvasive aspergillosis, as this may mimic the main solid nodule may mimic like a halo sign, giving halo sign. And I was also
Okay, but
suspect.
angioinvasive aspergillosis will not come ground glass
Yes.
only. It
Yes.
will come
Yes.
opacity with
Yes.
ground glass.
And that,
Okay.
yes.
So we are dealing with malignant mass
Yes.
invading the surrounding lung parenchyma. Other ground glass, another one ground glass, clear both lung fields. There is some mediastinal lymph nodes, but not so grossly. It is a case of adenocarcinoma, okay? Can you know the management of pulmonary adenocarcinoma?
I will refer as this is now a case of pulmonary adenocarcinoma. I will advise CT chest abdomen pelvis, staging CT chest abdomen pelvis, as well as
Okay.
bone scan for the to rule out metastasis, and then I will refer the patient to the lung cancer MDT for the further management.
Okay, thank you. We will conclude this case. Only finding here, there is speculated lesion along the right paratracheal stripe. Okay, clear both lung fields. We recommend CT as a patient of bladder cancer. By the way, do you expect in the exam, the examiner will bring for you a known case of bladder cancer to tell him that I have metastatic pulmonary nodules in the lung? I don't
Yes.
think it is an exam scenario, okay? So there should be something else. You have to be logic in the exam, okay?
Okay.
So here there is nodules with surrounding ground glass. It is highly suspecting of malignant lesion. So another ground glass, which are stages, by the way, of adenocarcinoma.
Yes. Sorry, I didn't remember the stages.
No problem, no problem. Just give me 1 second. So it is a case of adenocarcinoma. You have to, as you told, for maybe need biopsy, for staging, for this case may be treated by lobectomy, okay, or stereotactic radiotherapy, okay. Thank you, candidate 7. We will go for candidate 9.
Yes, Dr. Assalamu alaikum.
Walaikum assalam wa rahmatullahi wa barakatuh. Candidate 9, we have 30 years old female patient with deep central chest pain. Can you ask for the remote control?
Yes, I will. Thank you. Okay, this is CT chest axial cuts with intestinal window for a female, 30 years old female patient presented with deep central chest pain. I will scroll through the last cut, then I will give my comment. Okay, this is the last cut. This is non-contrast scan, which I can see that there is extensive calcification of the aorta noted, and there is a medial displacement of the calcification with surrounding slightly hyperdensity noted surrounding the aorta, and there's mild displacement of the trachea. So for a patient presented with central chest pain, with this signs, I would like to check also the arterial scan, because I'm suspecting this might be a dissection of the aorta. There is no pleural effusion noted, and no pericardial effusion. Also, heart is not enlarged, and within limitation of this study, I can't see any just prominent, significant hilar or mediastinal lymph nodes.
Okay. This patient is 30 years old, female patient.
This is weird to have
Is it accepted? Yes, to
no,
this. Okay.
it's not accepted to have this extensive calcification of the aorta.
What
So
about the mediastinal fat?
mediastinal fat. I can see small lymph nodes noted mediastinal fat. I can see that here surrounding the aorta, I can see that there is slightly hyperdense, maybe hyperdense
Okay.
hematoma.
Could be hematoma or like this common young
And
patient
there
like
is
this.
fat stranding noted within the mediastinal
Okay.
fat. This may be
Very
also
good.
a case of vasculitis
Okay.
for this
Very
young
good.
age.
Very good. Okay. Take the post-control. You have to convince the examiner that you are thinking good, okay?
Yeah, okay.
Not just I am talking, give him some finding, give me the post-contrast.
Okay. Yeah, so by scrolling, I can see that there is also in the branches of the the branches, the arch of the aorta, I can see that there is a wall thickening noted surrounding them and surrounding the aorta as well. Yeah, more in the ascending and the aortic root. And I can't see no intimal flap noted, no penetrating deep ulcers, no pseudo aortic aneurysm. Okay, I will go through. Yeah, so this is the last cut. So yeah, for this case, I think this is a case of vasculitis of the large vessels involving the aorta and the main branches of the aorta. In young age, I will think about Takayasu disease. So I would like to check the prior imaging for the patient. If the patient is a known case of vasculitis, or if the patient is not known, I will flag the report to the referring clinician. This patient need urgent referral to the vascular team.
Why urgent?
As the patient has a central chest pain now.
Okay.
And so this may be an acute exacerbation of the vasculitis need management. And this patient, I think it should be discussed also in the vasculitis MDT if the patient to control the symptoms.
What are the common vessels involved in the arthritis?
As I know, it involves the large vessels, the branches of the aorta and the aorta. I'm not really sure about and also the splank vessels like celiac and superior mesenteric may be involved.
Okay, what are the complications of arthritis?
May cause infarction to the affected organs, and vasculitis also might cause hemorrhage. I can't remember really the rest of complications.
Do you know anything about the treatment of vasculitis? Pediatric?
Steroids. The vasculitis is treating by steroids.
Okay, thank you.
Yeah, thank you.
Well done. Okay, here, 30 years old female patient, central chest pain. Okay, which will come in our mind first. It is acute aortic syndrome. Okay, but leave the mouse, please.
Okay, I'm trying to mute myself.
No problem. Okay, so you will find calcification along the aorta, descending. But here, if you look at the surrounding, there is thickening around the calcification. Okay, and also here, down here, also here. So here also hyperdense thickening fat of the mediastinum. You can see the fat here. Fat is black. Here, all the fat of the mediastinum is smudged. Okay, there is some lymph nodes. So you have to tell the examiner, okay, I want to exclude because of this, as you told, central chest pain. I have to do contrast to exclude any acute aortic syndrome, but I have another possibility, maybe because of the age of the patient, case of vasculitis. Okay, very good thinking. Okay, after you got the CT, okay, it confirms the presence of aortic wall thickening. It is extending through the whole branches, right brachiocephalic, left common carotid, left subclavian, and go down to the aorta. Okay, I have to comment on the coronaries also, but coronaries here are patent, so no involvement of the ostia of the coronaries. So it is a patient of vasculitis. Large vessel vasculitis means like arthritis. Okay. Common vessels included like aorta, carotid, subclavian, maybe renal, and pulmonary vessels. Okay. Complication of any vasculitis: stenosis, like stenosis of coronary ostia, or occlusion, aneurysmal dilatation because of the weakness of the wall, maybe hypertension due to involvement of the renal vessels. About the, we can do FDG PET CT. If there is increased uptake, it will be active disease. Okay. Also, MRI, if there is enhancement of the wall, it will be active disease. Okay. Treatment will include steroids, systemic steroid, maybe immunosuppression. In the complication, we can do angioplasty or stenting or bypass surgery. Okay.
Okay, thank you.
Thank you, Kantmai.
Thank
Well
you.
done. Last candidate. And 10.
Can you hear me?
Yes, but your voice is far away.
Can you now?
No such more improvement. Your case, 35 years old female patient with dyspnea on exertion and right pleuritic chest pain and decreased breath sounds.
I'm presented with the frontal chest radiograph of a 30 years old female who presented with symptoms of lower chest pain and pleuritic chest pain. I can appreciate that there is a ill-defined opacity noted in the right parahilar and right lower lung zone. There is a involvement of the lateral part, littlemost extent of the right lower zone as well. There are some prominent nodularity noted in the both upper zones as well in a suprahilar location. There is no evidence of any blunting of the diaphragm. The lung volumes are maintained. There is no evidence of any tracheal shift, no evidence of any hilar prominence, and no other lytic or sclerotic rib lesion is noted. There is no evidence of any changes in the bone, in ribs, or humeral head. I would like to advise a contrast enhanced CT chest study, as I'm suspecting in a 30 years old, it can be a patch of consolidation. It can be an atypical infection, or another possibility, less likely, could be a malignancy. So I would also be concerned about the previous chest radiographs of the patient. If the patient is known case of any previous disease like cystic
Okay,
fibrosis.
if you are suspecting infection, you will go for CT with contrast.
No, I would like to have a. I would
Patient
like to have.
no constitutional symptoms, just dyspnea on exertion, pleuritic pain, decreased breath sound. Anything
Okay.
else?
There are dilated bronchi noted in the right upper lobe as well. So I'm concerned about any background lung disease like cystic fibrosis as well. It can be an superadded infection in the background of prior lung disease, or it can be
Okay,
a allergic bronchopulmonary aspergillosis or
this is a
patient.
zoomed image on the central mediastinum. Can you see anything?
There is a bilateral paraspinal mass noted, opacity noted, projecting on both sides of the spine. It has there are blurry planes of the vertebrae adjacent to it have a blurry planes as well. There was a consolidation, a patch of infection, as well as bilateral paraspinal masses. So I'm suspecting a disease which is involving it could be a tuberculosis or it could be another infection, which can.
Can you see my mouse?
Yeah.
Anything here?
There is a nodule here.
Okay. What are you suspecting?
So can you please zoom out?
Yes.
Okay. It can be Port's disease or it can be metastatic disease. There is, however, no evidence of any breast asymmetry, no previous surgical clips noted. Thyroid region is not showing any clips. No evidence of any clipping in the region of kidneys.
What
But
about this
there is
area?
Sorry?
What about this area?
So
Overlying the
there,
right cardiac border.
it is showing widening as well, and there is air foci within it as well. So it can be continuation of the infection in the paraspinal
Okay.
location, in
Ask
pericardic
for the remote
location.
control, please. Approved. You can scroll.
Okay. These are the CT chest contrast enhanced images in the lung parenchymal window axial section of the same patient. At the level of right mainstem bronchus, there is a filling defect within the right mainstem bronchus. There is evidence of dilated bronchi in the right lower lung zone, some of them reaching up till the periphery with the peribronchial thickening. There are centrilobular nodules in the right lower lung zone. There are branching opacities and pleural effusion, area of consolidation. There is a fissural fluid as well. So the cardiac size is enlarged. The contralateral side is not showing any treen but opacities, but there is an extensive endobronchial spread of infection in the right upper, mid, and lower lung zone with a gradient towards the right basis. And there's a large opacity in the right lower lung zone as well. I would like to see it in the mediastinal window.
Is it an opacity or consolidation?
It is a consolidation with surrounding ground glass opacities and multiple centrilobular nodules. So this is the contrast enhanced mediastinal window. There is again an area of consolidation, and I saw a filling defect in the right main bronchus at this level. So there's a patch of consolidation. Sir, I would like to see it in the coronal images to see the mass which is obstructing the right mainstem bronchus.
Leave the mouse. Okay. Here is the coronal. Give me your final diagnosis, please.
There is an extensive lymphadenopathy I would just like to see the. So there is an endobronchial mass which is enhancing. It has an endoluminal and the exophageal component which is leading to area of consolidation. There is adjacent spread of the nodularity was most likely in keeping with the spread of the metastatic spread of the disease. The lesion which is enhancing looks like a malignancy, and there is an adjacent area of consolidation due to its mass effect, due to the obstruction of the lesion, and there is a pleural thickening which seems to be likely the continuation of the same malignant disease process. So findings are in keeping with endobronchial malignancy with adjacent spread in localized within the right lower lung zones. I will advise a staging CT chest abdominal pelvis. I would also like to see it in the bone window images.
Anything
To look
else?
for any.
Any other pathology? Any other pathology?
Any other pathology?
Endobronchial lesion, young patient.
Endobronchial lesion, young patient. It can be a carcinoid.
How will you confirm?
I would confirm with gallium dotatate scan.
We did PET CT.
So it's the PET CT, and I would like to see the enhancement in the area of lesion. It was in the. So there is no significant increased uptake is noted.
Okay.
But that doesn't exclude the carcinoid because
Okay. Very
they are
good.
not. So that doesn't exclude it. So I will advise a gallium dotatate scan or
What is the
MIP.
what is the role of FDG PET and carcinoid lesion? Do you know?
FTG PET is if it is showing uptake, it can be a central bronchogenic carcinoma.
I'm talking about carcinoid.
Yeah. So carcinoid doesn't show up in the PET CT.
Carcinoid is a benign lesion or malignant lesion?
Carcinoid has both features. It can be benign as well as malignant. So to see distant spread, we can see PET to see distant uptake. But for the
Okay. Here is a gallium dotatate. Which
okay,
gallium do we use in dotatate PET? Which type
gallium
of gallium? Yes.
67.
No. Gallium 68. Dotatate?
60.
68. Okay.
Okay. So at the level of the right mainstem bronchus, at the level of the enhancing lesion, there is a significant uptake is noted, which is in keeping with the carcinoid tumor. I don't know what the PET was.
Okay. How will you manage this case?
So I will urgently advise a referral to the respiratory team for discussion about the excision of the region, as it can lead to complete right lung collapse and it can further lead to superadded infection. And I will advise staging CT chest abdominal pelvis and a resection and a discussion in the chest MDT.
Okay, what is the most common sites for metastasis for carcinoids?
Carcinoid can be seen in bones, liver, and in the abdomen.
Okay. Can we find needle biopsy this lesion?
Can we what?
Fine needle. Take fine needle biopsy from this lesion.
No, we can't do the fine needle. It has to be excisional. There is a reason that if it is hormonally active, then it can lead to some crisis. So we don't directly put a needle in it.
Okay. Do you know what is the treatment for this lesion?
I only know about excision, and if they are distant metastasis, then radiotherapy.
Okay, well done. Thank you.
Thank you, sir.
Okay, the plain radiograph here you describe well there is opacity here on the right lower lung zone, partially obscuring the right heart border. Left lung is clear. I give you zoomed image here. So it's likely to be endobronchial lesion. We did CT. I didn't like from you filling defect. Okay. It is likely to be obstructing or partial obstructing soft tissue mass. I will look for the mediastinal window. Okay. This is slightly enhanced, causing consolidation of the right lower lung loop, right middle lung loop. Okay, no other nodules I can see. There is multiple tree and bud, which may be as complicated infection, okay, from the obstructing lesion. In a young patient, so you have to put carcinoid of endobronchial lesion. If it showed some calcification, you have to put carcinoid. Okay. Other differential, maybe squamous cell carcinoma, maybe hamartoma, maybe metastases like this. Okay. But carcinoid is very important to put. By the way, FDG bit in carcinoid, if there is low uptake, it is well differentiated because carcinoid is a malignant mass. If there is more uptake, so it means it is aggressive lesion. Okay. We can do fine needle, but we have to avoid it because it may cause carcinoid crisis because of release of histamine and serotonin, may cause cardiac arrest or severe hypotension and arrhythmia. Also may cause bleeding and seeding. Okay. We can confirm by doing gallium dotatate, which is new than ectreotide scan. In gallium dotatate, we use gallium 68. If there is uptake, it will confirm the presence of carcinoid. The curative management surgical resection. If the patient is inoperable or there is metastases to the liver or lymph node or wounds, we can give somatostatin analog, or patient may take chemotherapy or radiotherapy. Okay. I have some slides about our cases today. I will try to finish it quickly. We talk about sarcoid. Most important features of sarcoid is lymphadenopathy. Okay. You can see multiple lymphadenopathy here along the paratracheal, prevascular spaces, carinal, subcarinal, like this, and also here. Maybe eggshell calcification, but come with sarcoidosis or silicosis. So if you saw, and the histoplasmosis also, if you saw any eggshell calcification, it carries differential. Also here, perilymphatic nodules, micronodular pattern. Here, periphyseal nodules. It is specific for the sarcoid. Peribronchovascular nodules for sarcoidosis. Also here, maybe perilymphatic, peribronchial, fissural nodules for sarcoid. Here, beaded appearance of peribronchovascular nodules. Here, peribronchovascular also. All this about sarcoid. Also, nodular coalescence here and here. Okay. And here's the galaxy sign. If you make zooming, there is a galaxy sign, which is parenchymal distortion of our conglomeration of nodules of the sarcoid. Okay, there is sarcoid also may develop cavitary lesions. So and also it may cause progressive massive fibrosis of the lung. Also may show some ground glass opacification as well as fibrotic changes. Also, there is trapping. Also may come with sarcoid. Okay. Along the anterior mediastinal masses, here is the anterior mediastinal boundaries. Here along the axial section, it contain here the normal thymus. Normal thymus always be concave on in surface. surface of the normal thymus concave and wrapped over the vessels. Okay, and here on the sagittal section, we know that differential diagnosis for anterior mediastinal mass lesion for teeth may be thymoma or thymic lesion, may be teratoma or lymphoma or thyroid lesion. Okay, here in the chest radiograph, okay, there is here silhouetting of the right cardiac border. On the lateral view, there is extension to the clear retrosternal space. Here also on the left side, there is exploration of the left cardiac border, which confirms the presence of anterior mediastinal mass. Here is the thymoma, maybe benign thymoma. Thymoma may show some calcification, some cystic changes. Thymoma also may cause drop metastasis, will be thymoma or thymic carcinoma. Okay, and here along the peritoneum and the pleura and also paravertebral line. Here also there is thymoma that cause invasion of the mediastinum. It is here extending to the right atrium. So invasive thymoma is a possibility also. Also thymoma. Here, thymic carcinoma is calcification, cystic changes, invasion of the mediastinum. So it may be thymic carcinoma. The signs of thymic carcinoma is heterogeneity of the lesion, drop metastasis, invasion. We saw today a case of invasion of the superior vena cava, invasion of the right atrium. Thymoma may be aggressive lesion or thymic carcinoma. Okay, this thymic carcinoma also may cause drop metastasis of the brain, may cause liver metastasis, may cause bony metastases. Or thymic hyperplasias, normal thymus, but it become convex, not concave. So, and the thymus also has measurements, I think about 16 millimeter from 20 to 30, about 5 millimeter the edge of 50. So this patient, 4 to 5 years old, so it is enlarged, but it is thymic hyperplasia. Here the lymphoma, third one, multiple lymph nodes. In the X-ray, it will cause bulky hilum like this, and also lobulated. Also here, Hodgkin lymphoma. Another one. It calls also floating vessel sign. Encircles the vessels but not invading it. Is lymphoma. Lymphoma. Also lymphoma. Here's the teratoma. Teratoma may contain fat, may contain calcification. Okay, comes slightly in young age, 13 years old boy. Okay, here is the thyroid. If you see the coronal, it is seen extending from the neck. Okay, cavitary lung lesions. Here, cavitary mass. Most common cavitating lung cancer is squamous cell carcinoma, which is always related to smoking. Here is necrotizing pneumonia, may cause cavitation also. Here is necrotizing pneumonia. Here, cavitary lesion with air fluid level, which means lung abscess. Here, another one. Here, lung abscess also. Here, septic emboli, thick wall cavitary lesion with patient of infective endocarditis. By the way, infective endocarditis and the cardiac visitation now very common exam case. Okay, here septic emboli. Here is the cicatrization of the lungs and this cavitary lesion of all the pulmonary tuberculosis. Also tuberculosis with cavitation and tree in bud. Tuberculosis with cavitation, tree in bud. Also tuberculosis. Here, mycetoma or aspergilloma, here crescent sign. Also, aspergilloma with this changes with the patient position. If we change the patient position, it will go here and here. So it is aspergilloma. Here, after the patient changed the position, here it is posterior. Here is go posterior in a different position. Is aspergilloma. Here, post-traumatic pneumatocyst, the patient is surgical emphysema here and brief fracture. So pneumatocyst can be capillary lung lesion. Cystic lung disease, we have to know is real lung cysts. If no, maybe cavity or poly or pneumatocyst or emphysema, honeycombing, cystic bronchitis. Okay. We will differentiate between solitary and multiple lung cysts, localized or diffuse. Solitary cysts may be incidental, may be congenital cystic disease like bronchogenic cyst, multiple congenital lung cysts like CPAM, multiple diffuse associated with other finding. Okay, here nodules, LCH or cystic metastases, ground glass, PCP, DIP, LIP, maybe no other finding, lymphangiomatosis with tuberous sclerosis, or Birt-Hogg-Dubé disease, which I think related to renal disease. Okay, this is bronchogenic cyst. Here, CPAM, common exam case, long cases show and VIVA cases. Here, LCH, bizarre-shaped cyst, sparing costophrenic angles. Cystic metastases, hemangiosarcoma, squamous cell carcinoma, amyloid, PCP. If you found ground glass opacification, cystic changes may be complicated by pneumothorax, immunocompromised patient, so you have to think about PCP. Also, DIP, here, there is small cysts, ground glass opacification, smoking history. LIP, Sjogren syndrome. So you have to, and there is lung cysts maybe come with ground glass opacification also, but randomly distributed lung cysts. So, and with the history of Sjogren syndrome, you have to put LIP. Here, a LAM with tuberous sclerosis, uniform distribution of the lung cysts may be associated with chylothorax or pneumothorax, tumors, subependymal hamartomas, and here's the left lung pneumothorax, multiple angiomyolipomas of the kidneys. So it is tuberous sclerosis with LAM. Part Birt-Hogg-Dubé syndrome, I think related to with oncocytoma or renal tumors, and also lung cysts and may be complicated by pneumothorax. Here, diffuse opacities of PAP, pulmonary alveolar proteinosis. Here, there is some ground glass, interlobular septal thickening, maybe some lung cysts, but I think it is incidental, not related to the disease. Same PAP. Different picture here, the sparing, well definition of secondary pulmonary lobules. Another one, here there is pneumothorax. There is RDS with crazy breathing also. We told crazy breathing acute or chronic according to the presentation of the patient. And here the COVID pneumonia also may come with crazy breathing. Here, this for adenocarcinoma. If it is ground glass, it is called atypical adenomatous hyperplasia. Okay, or adenocarcinoma in situ. So the stages maybe come with ground glass, maybe here nodules with mixed ground glass and soft tissue density. So it is adenocarcinoma. Here is the stages: hyperplasia in situ, minimally invasive. There is some solid nodule. Here, the adenocarcinoma, it will be mixed solid and peripheral ground glass opacification. Here's some pictures of adenocarcinoma. Another one. Here is Takayasu arthritis. There is some classification of Takayasu arthritis. One will take the pulmonary branches, the aortic branches. Here, aorta, ascending aorta and its main branches. Here going to the descending aorta to B. 3, it going down to the, I think, level of renal vessels. Here, renal vessels only, and 5, it will take all ascending main branches and descending till the renal vessels. Okay, this carcinoid come in the bronchus about 10%. Right upper lobe will take 80%, middle lobe 16, 17 on the lower lobe, and the same on the left side. Here is the lesion on the bronchoscope. It may cause iceberg sign. Some of the parts of the lesion come inside the bronchus and the other outside the bronchus. Okay, this is pathological types. Here is a carcinoid here, can cause some collapse or consolidation and some calcification. Also, it comes in young age. Here, another one of iceberg sign, some component inside, some component outside. Okay, here is a visual bronchoscopy. It is cause compression of the bronchus here. If you can imagine, it may be some outside and some inside. Here's calcification inside typical carcinoid. Another one. All the same here. Upper lobe carcinoid, upper lobe bronchus carcinoid, can come lower lobe and upper lobe. Large mass here. Another one, central bronchial lesion. Large mass lesion, maybe pulmonary, but it is endobronchial and extending outside. It is a typical carcinoid. Okay.